All right, Elise, if you want to get started.
Thanks. Welcome, everyone. My name is Elise Everett. I'm up here at the University of Vermont, and I'm here today to introduce our speaker for the Alliance for Clinical Education Clinical Faculty Development Series 101. I'm going to be hearing about assessment and grading today. And our speaker is Dr. Edward Krupat. He's the retired director of the Center for Evaluation at Harvard Medical School. Currently holds appointments in the Department of Medicine at the Beth Israel Deaconess Medical Center and the Harvard School of Dental Medicine. And he serves as the Medical Education Research Specialist in the Brigham Education Institute of Brigham and Women's Hospital. He holds a Ph.D. in social psychology from the University of Michigan. Dr. Krupat's work has focused on student assessment and the evaluation of innovations in medical education. In addition, he's developed instruments to assess the medical school learning environment and physicians' attitudes towards patient-centered care, and studied the process of diagnostic reasoning among physicians. So welcome, and we're all really excited to hear you talk today.
Well, thank you. Let's see. I think I should be starting, if I'm correct, with the standard kinds of statements about CME credit and things like that, and disclosures. I have no disclosures. I like someday maybe to have something to disclose, but I'm disappointingly boring in terms of never having disclosures on my own. Let's see. This is part of the Clinical Faculty Development Series. You have likely seen these slides before, but just want you to be aware of the fact that it is a 3-year series with 9 webinars per year, and based on the guidebook for clerkship directors, the 5th edition. You can see here many fascinating topics and wonderful sessions that have been held so far. And today, May 12th, we're going to be talking about assessment and grading. Coming up, you can see things that are on a long line, and it should be really interesting batch of programs. Keep on going. Great topics. And this talk is based on a chapter in the guidebook. I didn't use this space somehow to identify the number of the chapter, but it's the chapter called Assessment and Grading of Medical Students, so it's pretty straightforward. What I'm going to be saying today derives from that and expands on that, since that's a few years old, and I've got an opportunity to offer some thoughts and opinions. So I have several objectives today. I want you to be able to understand and be able to apply practically a whole batch of things. First of all, the question of why we assess in the first place. What purposes can assessment serve for you, for us as medical educators? Second question is, what makes good assessment? Because people often find assessment problematic. So the question is, what's the difference between good assessment and assessment that's not so useful? Third question that I want us to address is, what should we be measuring if we're going to be assessing? And I'll use measuring and assessing pretty much interchangeably, if I may. And then I want to ask how we can, or at least how we should, turn assessments into grades. I know many of you, if not most of you, are involved in clerkship leadership, and very often there's the question of applying grades. And what I should say in advance, by the way, is that, well, two things. First of all, based on the first line of this slide, I'd like this talk to be very practical. I have listened to many kind of pedantic, I shouldn't say that, excellent, but very academic talks about assessment, in which I felt I didn't come away with the kinds of information that I could really use and that would help me deal with some dilemmas that I come across. So I want it to be practical, and then I would also like it to be specific to some of the things you're dealing with and the challenges you face, while recognizing, however, that there are no simple answers for most of these. So I'd like to give you informed opinions. I'd like to give you pros and cons. And while there are some don'ts, the very best of do's are hard to know. And I think it would be irresponsible of me to say I'm going to give you simple, straightforward answers. I hope to be able to tell you that these are issues that are complex. These are the criteria by which you can base your decisions, but that the person next to you or your colleague on a committee is likely to have informed other opinions. And this is a field where I wish there were right and wrong answers. So we're going to deal in this hour, I hope, with reasonable shades of gray. And I hope I'll be able to leave some time for questions for you to follow up on things you don't agree with, you don't understand, things that need to be addressed further. So let's start by making this just a little bit interactive and asking you a poll question. And I'm going to say, concerning your knowledge and skills in assessment, would you say, that you're extremely competent and confident, that you have some good skills, but you'd still like to improve them, or that you really feel that your skills aren't that strong? I'd be really curious to hear what your thoughts are, what this audience believes. So please plug into one of those three. Okay, we're quickly up to 80%. Good for all of you. Let's see if we can get just a little bit higher. Nice, quick responses. Okay. I'm going to give us just a couple more seconds. A couple extra people might have come on. We're almost at 85. Come on, let's add one more. Once we're there, we can end the poll. Well, let's end it regardless in 5, 4, 3, 2, 1. Last chance. Let's share the results. Okay. If you can see, the vast majority of you are where I think the vast majority of people who aren't in the room today would say they are. 15% say, it's a shame, I wish my skills were stronger, or I don't feel. It's only 5% that who say you feel extremely competent and confident, and good for you. It's nice to feel that way, and you probably have good reason to feel that way, but the vast majority of you are kind of in that middle ground. And that's where, let's see if we can do something today to move some of you over, at least from good to extremely competent and confident. So I'm going to start with saying, what purpose does assessment serve? What function does it serve? And start out with the distinction between formative and summative assessment, which I think is an important one, and I don't see discussed as often as I might hope. Summative assessment is what we all think of, and certainly what your students think of when they think of assessment. It's the test at the end of the course. It's the shelf exam. It's the final exam. It's the licensure exam. It's a test form of assessment where the goal is to make a decision about pass, fail, advance, not advance. And in fact, it's seen as an occasion. It's a one-time shot usually that happens at the end of something. Am I ready to graduate? Am I ready to be licensed? Am I ready to move on to the next year or whatever? And it's consistent with what Carol Dweck, who's an influential psychologist, has called a performance mindset. And that is, the idea in summative assessment is, I gotta pass the test, gotta pass the test. I wanna be good, I wanna get the highest grade. I wanna be able to move on. I gotta show what I know. Formative assessment is very different. It's a type of assessment, it's a type of testing where the goal is actually not making a decision about progression, but improving knowledge and skills. And again, we don't often think about assessing having a goal of improvement. In formative assessment, the learner receives useful and detailed feedback. And there are programs that I'm sure you have and will take on how to give good feedback. But a key part of formative assessment is to observe, is to test, and then to give people feedback. So it's seen as a constant process. It's something that happens over and over again. It's something that even happens often. And it's consistent with what Dweck calls a growth mindset. The idea that I can get better as a student, and for you as a faculty member, the idea that I want my students to get better. To elaborate a little bit more on formative versus summative assessment, you could say that there are two worldviews, there are two mindsets, there are two whole ways of structuring what assessment is all about. There's a wonderful distinction that's been drawn between summative and formative, which is to say that summative assessment is the assessment of learning. What do you know? What can you do? Whereas formative assessment is assessment for learning. It's not so much to learn what you're able to do, but to make sure that through assessment, you're able to do things better. Summative assessment happens relatively, not very often. I remember when I was in college, I always used to say, I came into a class somehow, and some classes said to me that there would be weekly quizzes, and others said that there would be a midterm and a final. Summative assessment, can be a weekly quiz, but it's usually low frequency. It's that midterm or final. But there's a lot riding on that. You better not mess up. It's a real high stakes thing. And when your students, I think, typically think of assessment, and again, I use the word testing interchangeably, it's stress laden, it's threatening. It's, oh my God, the test is coming up. Oh, I better study, I better do well. Whereas when we think of assessment from a formative perspective, the term high frequency, low stakes has often been used. It's something that happens often, but there's not a lot riding on it. There's nothing terrible. And in fact, ideally, in an ideal world, it's low stress and even welcomed. If you can have a group of students saying, well, I want to be observed, because how else am I going to learn what I'm good at and not good at? And how else am I going to improve? Then I think you've got a great system. But I don't mean to be pitting summative against formative. And I don't mean for you to think that I'm saying one is better or more important than the other. I'm in fact wanting to tell you that a system almost has to have summative assessments, but that which builds a formative mindset into all of its assessments is one where students grow and develop and are not burnt out and stressed. So let's ask a second question. What makes for good assessment? back in 2010, there was a conference, the Ottawa conference, in which a bunch of hotshot assessment people, who forgot to invite me, I guess, came out with a statement. And the statement is in a really nice Ottawa conference paper, and it's longer than this. But these are what I kind of abstracted out of their key points. One, that good assessment should be useful for its intended purposes. And we'll talk in a moment which bears on the validity of assessment. But make sure you're assessing things and it has a good purpose. It should also be consistent and reproducible. And that is, make sure that your tests just don't get random scores, but that students should be able to show some consistency over time on the assessments that they take. Obviously, a good assessment has to be practical. It has to be feasible. I know some of my colleagues are very pro-OSCE, and some of my colleagues are not so pro-OSCE, if nothing else, because OSCEs are resource eaters. You've got to either have your own or work with or train standardized patients. It takes a lot of time out of the day. Obviously, if it's not practical, if it's not feasible, then it's less useful. So good assessment is something that doesn't eat up resources unreasonably. A fourth aspect of good assessment is that it should motivate learners to develop knowledge and skills through preparation. One of my favorite teachers once told me that she cared less about our taking the test than our preparing for the test, because we were motivated to do so because we knew we were being tested. In fact, she said, if I could just have you come in the day of the test and say, no, test is canceled, we accomplished the most important purpose. You studied and you learned. She said she'd love that, but of course, if that came to be known, people might not study and learn if they knew the exam was going to be canceled. But it should motivate learners to study, to prepare, to develop. And it should provide, in the spirit of formative assessment, feedback, again, for improvement in skills. And by the way, I should say that even summative exams can be designed such that they do provide feedback. And that is that you passed, in past years, the step 2 CS, you got a passing score. But by the way, these were your strengths and these were your weaknesses. That's the only way you ever got feedback on step 2 CS was if you failed. And I'm not so thrilled about that. But ideally, good assessment provides feedback. Now, when you hear assessment discussed, what you will hear basically every 3 seconds is, oh, well, it has to be reliable and valid. And people toss around those terms loosely, interchangeably, incorrectly. And again, I like to think that my medical school, Harvard, has a lot of very smart people, and it does. But if I told you how many times I heard those words used in ways that I wasn't too happy with, it was common. So let's give a test. Question 2. The new dean for admissions wants to try an easy way to determine which students should be admitted to your medical school. And this could be to your residency program instead of medical school, if you prefer. She wants to measure the hat size of all applicants, admitting those with the largest heads and saying no to those with small heads. So if you think about this method of assessment, measure their heads or their hats, take the ones with big heads and get rid of and say no to the ones with small heads. Would you say that this is an assessment method that's both reliable and valid, reliable but not valid, valid but not reliable, or neither reliable nor valid? We should have the choices up. There you go. Let's see what people say. We're up to 79%. Let's get a little bit over 80 if we can. There we go. One or two more if we can. There are 8 of you who are still hedging your bets. Great, thank you. Let's go 5, 4, 3, 2, 1. Okay, let's share the results. So first of all, you're a great audience, and I should be intimidated because this is the first time I've ever asked that question where the vast majority of the audience got it right. So hooray for you, who said reliable but not valid. And you could almost inform the rest of us about why that's the correct answer. But I will say I've asked this question to medical educators in the US and throughout the world. And typically the vast majority, as 26% of you said, not reliable and not valid. And in fact, most people in my experience say that, but again, not for you audience, you're hooray for you. Simply because this sounds like a stupid method. God, what could be more ridiculous than doing that? It's not good, and not good becomes not reliable and not valid. I see a hand. Let's see. Can someone ask? You can ask a question. I didn't see whose hand, and I don't know how to make.
Ed, it's Vijay.
Yes.
All assessment is based on some assumption or a judgment or observation prior.
Right.
Assessment doesn't happen in vacuum.
Right.
So in this case, the assumption is the head size is make a difference, that if I get a student with a bigger head size, will have better performance in a school. So the assumption itself is pretty wrong. So I think that's why I chose not reliable, not valid, because right from op-ed, the judgment, assumption, and observation is wrong.
Okay. Well, let me, by the way, in response to your question, I'm not avoiding your question. I've got 2 slides that follow up that address what your comment is directly. Okay, so Vijay, I thank you for that comment. That's a good one. But let's talk about reliability and validity. And I hope that it addresses just what you've asked. So I'm going to move on for a moment. Okay. And let's start talking about reliability. Reliability involves the consistency of a test, or technically it should say the consistency of results of a test. And people often talk about 2 kinds of reliability: inter-observer reliability and test-retest reliability. Inter-observer reliability asks the question, do 2 or more observers or graders give a similar or identical score? If 2 people disagree, then it's unreliable, and we don't know whose opinion to take. That's why, and in fact, this is a typical problem in clerkship grading, because in fact, we often get people disagreeing, seeing people different times, different ways, and we worry about subjectivity. Subjectivity really says we're concerned about inter-observer reliability. Test-retest reliability, we don't often give the same test over again, but I think test-retest reliability can be explained in the following way. And that is, I get on the scale in the morning and I look down and it says I weigh 165. And I say, oh, gained a couple of pounds. And I get off it for a moment and I get back on it. and it says 165. Now, why did I do that? I wanted to see if it's a reliable scale. Imagine that I got off it and it said 197. I'd say, which is right? I've tested it again and I came out with the same thing. By the way, what if it said 342? Got on it again, it said 342, and I got on a third time and it said 342. Is this scale reliable? The answer is yes, it's perfectly reliable. But are the results valid? Now, I could give you a long, boring lecture on the different types of validity, but I think there's one kind of validity that gets talked about too little in medical education: predictive validity, which is the most important criterion. And I think, Vijay, this is what you were talking about. We ask, does a student's score on a test help predict his or her behavior or performance on a relevant future measure? Does MCAT, is it a valid predictor of medical school performance? Was step one a valid predictor of residency performance? And to the extent that it's not, we would think, Vijay, that your head size, there's enough evidence that the size of a head and intelligence are not correlated. So that would be a perfectly reliable test, head size, because it's easy to measure, and it wouldn't matter who did it. It would pretty much come out the same, and it doesn't change over time. But we would guess that the correlation between head size and performance would be close to zero. So it would be highly reliable, but not valid. Next thing, let's move on and say assessment of what? Well, you know, the classic approach is knowledge, skills, attitudes, KSA. It usually goes up on the blackboard. And it's still a very useful way of thinking in general about what we assess. What do students know? What can they do? And what are their attitudes? And by the way, attitudes we can think of, I've been asked, you know, what do you mean by attitudes? Well, how does the student feel about various things relating to professionalism? How do students feel about relating to patients? Some students may be more patient-centered, whereas others may be more doctor-centered in their way. Same as, by the way, patients may have different attitudes about care. Burnout is also, to some extent, a measure of attitude. So classic knowledge, skills, attitudes. And then, around 1999 it was, I think the ACGME came out and said, you know, this is not specific, this is not measurable. We want to talk about competencies. And I would guess that everybody in the room has heard about the 6 ACGME competencies: medical knowledge, patient care, professionalism, etc. And they said, these are measurable. So let's talk about characteristics and attributes and skills of physicians that get us into a way that's more specific and direct in terms of assessment. So CBME, competency-based medical education, has become the term that we all have come to embrace, but it's around these 6 competencies. Around 2014, a group of distinguished medical educators came out and said, you know, competencies are nice, but they're still a little bit too vague. They're still a little bit too non-specific. They're still a little bit difficult to assess or measure. So let's make things more very specific and talk about tasks, behaviors, units of work that medical students must be able to accomplish, that we must be able to trust medical students to accomplish before they become residents. And the entrustable professional activity, or EPA movement, became really what grabbed medical education. More specific, more precise, more concrete, and hypothetically more measurable because one, it was about activities, and we could identify the activities that interns needed to have on day one. And two, it gave us physicians a good way of thinking, and that is, can we entrust? So here, by the way, I've talked on through my slides. We've said this already. And also, by the way, I didn't say that competencies are nice because they can be assessed longitudinally, often through the identification of milestones, and competencies and milestones went together. I've talked right through my next slide, vague, what do we mean? How can we measure professionalism? And let's get into more specific things. And then the point I was going to in this slide is to say, trustworthiness is something that resounds in the minds of physicians when they're talking about their students and their trainees. Can I trust this person to perform the activity at all? I mean, I've heard some people say facetiously, I almost didn't want the person in the room. I didn't trust that person to touch the patient or to be involved at all. Just to be an observer is the best I could hope. That's at the bottom. Or could I figure that this person is capable of performing the activity with direct supervision? I'll stand over him or her and correct and inform and direct, but I only trust that person to do it with my supervision immediately there. Or can I trust the person to do it with remote supervision? I'll be nearby. I'll be somewhere where you can catch me if there's a problem, or where I can, occasionally drop in and observe, but remote supervision. And then, as I've said, suggesting more relevant for graduate medical education, to perform independently. I don't need to be around. I don't need to do it. She's great. She can handle it as well as anybody else. And then we think of even beyond that, not only can that person do it, but that person is so good that he or she, as you progressed through your training, able to teach or to demonstrate or to show others how to do this thing. So what we've got is a progression from perfectly not trustable at all to perfectly trustable. And it's a good way. I will say that I'm not one of the bigger fans of EPAs. First of all, because I think there's tremendous subjectivity in what we've just talked about. What you would trust somebody and what I would trust somebody to do may be very different. And that's the question of inter-observer reliability. The other thing is that the EPAs, and that performing independently isn't a reasonable endpoint for most undergraduates, much more relevant for graduate medical education. And that one of the things that bothers me about the 13 AAMC core EPAs is that nowhere in there do you see anything about communication. And I've written and complained that communication is a task, is a behavior that should be and must be included, and that there's lots of literature to show you can assess it. But EPAs clearly are valuable, even if I've got some reservations about it. And clearly the coin of the realm. It's what people talk about and think about, and it's what students have come to care about, since it's what we care about. So let's get on to grading. Question 3 is, the best way of assigning grades to students is A, to use pass-fail, B, to use a system of honors, high honors, satisfactory, and fail. C is to compare student scores to one another and assign grades. D is to compare student scores to a criterion and assign grades. Or E, this is a hotly debated topic without a single best answer. if we can post this. Here we go, we're up to 80%. Let's get those few extra people in on our voting. Okay, up to 87%. Let's go 5, 4, 3, 2, 1. Blast off. So hooray for you all. You're a nice, wonderfully sophisticated group, and I would agree with you. It's hotly debated and without a single best answer. On the other hand, there are a few people who said chose D, and a couple of people who chose B. And are they wrong? And the answer is no. And in fact, let's now enter the debate and ask ourselves what goes. So first of all, we can ask ourselves, let's see if I don't want to miss my slides, about pass-fail grading. First of all, it's far less stressful. And there are many schools that have pass-fail grading. It is much more typical in pre-clerkship than in clerkship. And in fact, some schools go from pass-fail to some sort of multi-tiered grading system. And when there's pass-fail grading, the kind of terrible competition that we've all experienced in our educations, and that medical students, I think, still experience now, kind of melts away to some extent. Everybody can feel free to collaborate. A stronger student can work with a weaker student. A weaker student can be helped by, whether it's faculty or other students. Everybody can feel like they're just working together because the pressure isn't on to outperform anybody else. So it really does discourage competition and showboating. The so to speak gunners don't have to go crazy. Although at Harvard, for instance, where in fact the first 2 years are the first, well, it's not 2 years anymore, but the pre-clerkship is pass-fail. Of course, it's hard to keep the gunners from being gunners and trying to outperform. But the University of Virginia, a number of years ago, went from a graded system and pass-fail grading, and they did some wonderful research surveying students and faculty, and they did find that the whole atmosphere was down a whole level. And then the question is, does it affect learning? The people who don't like pass-fail grading will argue that it discourages excellence and a high level of motivation. If all I've got to do is pass, then why do I need to get, to demonstrate to myself, if not to others, that I really, really know this stuff? I can kind of ease off. I can kind of cool down. It's the same thing, by the way. Some people don't like the term competency because they say we're not trying to turn out competent physicians. We're trying to turn out excellence in physicians. Another con about pass-fail grading is, does it fail to differentiate among students? Maybe somehow we want to know. Maybe there's a value in knowing that some students are doing very well better than others, or perhaps even importantly, that we have to know which students are struggling. And if everybody's passing, and that again, my experience is that at my former institution, it was kind of a pass-pass system rather than a pass-fail system. Does it fail to distinguish people who really know their stuff? If everybody sort of passes, you know, what happens? There was a survey. Now, I mean, I've been focusing here most closely on pre-clerkship, because that's where you more often find pass-fail. But a survey done several years ago of clerkship grading. And maybe that should have been one of my other, you know, group questions. But what they found from a large national survey is that the percentage of students who failed clerkships was less than 1%. So, you know, ooh, that says something about, you know, regardless of the system, is everything pass? If you determine grades, oh, by the way, I'm going to move back if I can. No, okay. Yeah, before we get on to the next issue, what I'd like to say is in that question, it also said, oh, one of the things is I found schools and talked to colleagues where pass-fail grading gets snuck into, well, for the students we like the most, we've got a pass plus. And all of a sudden, you've got a three-tiered system. For clerkship grading, a national survey demonstrated not too long ago that 4% of the responding clerkships said that they were pass-fail. 13% said that they had 3 tiers. 80% had between 4 and 5 tiers, and 4% had 6 or more. One of the schools had 11 levels, and I imagine that's probably A+, A-, B+, etc. God knows, but they had 11 different distinctions. Also, by the way, are those I've just said this one school I was guessing might have had letter distinctions. Even when we've got 3 distinctions or 4 distinctions, do we give them names or do we give them numbers? What's distinction? What's excellence? What's commendable? What's high pass? What's honors? You know, it's been said, if you've seen one medical school curriculum and assessment system, you've seen one. So my guess is if there are 50 or more of you out there, there are probably 40 or more grading systems that you're all involved in. And the other question is, even if you have, Harvard once had, this is past, they've changed it, high honors, honors, satisfactory, and fail. And I hope I'm not, because they've changed this and recognized that it's a problem, is virtually everybody was getting high honors and honors. Well, they're Harvard students after all, what the heck? On the other hand, there was a rule that if you got if over the year in 7 clerkships, you got 2 or more satisfactories, you could go before the review board for purpose of poor performance. And you could even be considered, you know, to be tossed out of school. And I had always dreamt that my dream job was to be the lawyer that represented a student who was being thrown out of school for getting too many satisfactory grades. So there's a question, again, as I said, if 1% of the people are failing, you know, how good is our system, whether it's multi-tiered or pass-fail? So if we're determining grades, it's a question of how we should go about doing that. And there are 2 very distinct approaches, either referent or normative-based scoring versus criterion-based scoring. Referent or normative scoring is where we get a distribution and we compare the students' performance against one another, and then we maybe make some cutoffs. But everybody is somewhere in the line from top to bottom, and maybe 5% of the top 5% or 2% or 10% get the highest grade, and maybe the bottom 3% or 5% flunk and have to repeat a clerkship. The idea is that we're putting students, pitting them against one another, so that it's my job not simply to get a good score, but to get a better score than you do. So it, again, makes people competitive. And in fact, it probably guarantees that only so many people will get the highest grade, which students hate, and that some percentage will be determined because they're at the bottom of the distribution, even though maybe they're not doing that poorly, will get the lowest grade. And that's a real problem. So in fact, most people would agree that a better way to go is criterion-based scoring. So what's the criterion? You identify cutoffs not based on how people did against one another, but based on some pre-identified criteria. And that is, if everybody can exceed that criterion, then everybody passes. And if nobody can, well, you probably got too high a criterion, too high a bar, but if nobody can, then technically everybody will fail. And in fact, the National Board, all of its exams are criterion-based. But to be perfectly honest, for instance, when step 2 was CS was still around, they noticed that for all the money and time and effort, like only 2% of the students were flunking. And they raised the criterion. Well, if you raise the criterion, you're really having a referent-based system in disguise. See, if I were applying to be a lifeguard and I knew that I had to be able to swim 30 yards in a certain time because that's what it took to save a person, then a criterion-based scoring is spectacular because it's not arbitrary and it makes sense. If I'm a pilot and I'm being assessed in a flight simulator, and I'm given bad circumstances, stormy weather and wind and lightning, and the criterion is, can I land the plane safely? Then I don't care how many people pass or fail. If everybody who lands the plane safely should pass and everybody who doesn't should fail. So criterion-based scoring is, I think, what everybody would agree in principle is the way to go. But to find criteria that are arbitrary, other than saying 80% on the exam, is problematic. So grading issues. And I'll just raise them out there and you can toss them back to me if you want. How many levels of grades should there be? Well, as I said, differing schools, but the idea is to use all the levels and to, again, on that clerkship survey, schools reported that the highest grade was gotten, one school said by 20%, and another school said by 80%, and everybody in between. Can we be less subjective? Can we train faculty? Can we identify criteria? Can we get around bias? And God knows that's opening up a whole can of worms that we could go on for hours about the gender and racial bias. What does it take to fail? And when should students fail? And how to deal with our own concerns as faculty that, oh, I wouldn't want to fail that person because then it's gonna affect his ability to get a good residency. Or if I fail, yeah, I'm the one person who fails a few students every year, but oh God, do I get hell. I get it not only from the students and their lawyers and their parents, but also the dean. So these are tough questions. And then perhaps the toughest is the idea of forward feeding. And that is, if we identify a student in his or her first clerkship, and we know that that student could use extra support, a little extra observation, is it right for me to go and tell the director of that student's second clerkship that this person really, you should watch a little more closely, you should help? On the one hand, that could lead to real careful caring for a student who's struggling. On the other hand, people have argued that leads to what's called a self-fulfilling prophecy. And that is that now all of a sudden that student has been labeled as a problem student and is going to be, carry that along his or her own, whole year of clerkships. Tough issue. So some say assessment drives learning. And, we see that all the time in some of our efforts or our colleagues' efforts to teach the test. And in the form of the students, and if you've never heard a student ask this, I'd love to know what school you're on. Will that be on the exam? So where does that leave us? Some takeaways. I recommend that not simply as part of your clerkship, but part of your medical education system, you build a system that does what? Combines both formative and summative, where the tests and assessments reflect your goals, the goals of the objectives, values of the courses, clerkships, and the school's mission. That's what you should be testing on, what's important for them to know or be able to do. Where multi-source information of many different kinds of tests from many different kinds of people is integrated and organized, where everybody's pulling in the same direction. Faculty, students, administrators, advisors, mentors, coaches, mediation staff, everybody's working together and sharing information on behalf of the student, in which the assessment system, by the way, evolves over time based on input about what's working and what's not working, which is to say you should assess your assessment system, and in which there's total transparency, in which there are no hidden curriculum issues, in which a system in which students understand the whats and whys and hows of how they're being assessed and by whom, and how that information is being used. That's a brave new world. I've never worked in a system that was perfect on all those criteria, but that's something to aim for. So I'm going to stop. I think we've got a few minutes for questions, and I'm sure you have questions or comments. So Gary, are you out there to suggest some, or shall I just dig through the chat? Or Elise?
Yeah, excellent. Thank you. There's been lots of discussion in the chat, but I think it would be great to just open it up for questions from the group. And there's about 45 of you on, so maybe raise your hand and I think you'll come to the top. And if we don't see your hand, just feel free to unmute and ask your question. Everyone's trying to figure out how to raise their hand. Well, I can start us off. So I'm at the University of Vermont, and we went from a honors pass-fail system to a pass-fail system with COVID because we were just really worried about the inequities and what patients would be coming through the door and what faculty would be available, and just the impacts on families and single parents and people of color and all of the uncertainties of COVID. So we felt the most equitable thing to do was to go pass-fail. We just made a brave decision to continue pass-fail grading for the class of 2024, which is the current clerkship class. And we made the decision really based on three factors, looking at the literature and the evidence around student wellness was one, looking at the evidence around equity. And then the third was really looking at the evidence around the reliability and validity of the current tests that we have, which really aren't able to discern one group from the other. So ultimately, we've decided to go pass fail. So in terms of a question, I think during COVID, one of the things we noticed, sort of getting back to your idea of summative and formative assessment, that when we made things more formative, we saw students' performance decrease, I guess. And so trying to find this balance between having there be enough stress, but not too much stress. So enough stress to drive that push towards excellence, but not too much stress. It's been really, I think, a challenge for us to find that perfect sweet spot. So I'm just curious what your thoughts are on that.
Yeah, psychologists have developed years ago something called the Yerkes-Dodson law, which talks about the fact that many things are curvilinear. They go up to they improve up to a certain point, and then beyond that, like working under stress. The more stress you're under, up to a certain point, the more you'll perform. And then at some point you reach a high point and it goes down. I also refer to that as the Goldilocks phenomenon. The porridge shouldn't be too hot or too cold. And it's a wonderful challenge. And I'm so glad I got through my talk without saying the word COVID once, but I'll say it now, to manage how to make students feel responsible, and that there is a summative requirement at the end, and also to make them feel comfortable and not afraid. I mean, again, the first thing when I got into medical education was talking to students is I heard them say, fake it. That's the one thing you should do on your clerkships. A perfect performance orientation, never admit weakness, never admit uncertainty, take a chance. So exactly how to find a way. I mean, it may be, for instance, that your students know, and I'm not accusing Vermont of being any different than everybody else, that virtually all of them are passing. And by the way, you're going to have to get them into the excellent residencies that they deserve. And at that point, I didn't even talk about using qualitative methods. And that is, you'll be writing letters for them, perhaps. Now, again, do letters ever say, she started slow, but she's improved? Or although he's not always reliable, they talk in code. And what you do is you damn with faint praise. So that's just me ranting to your posing an excellent question to which there is no simple answer. But it is, I mean, as you implied in your question, finding a happy medium between making students realize that you are evaluating them and you will be writing letters and you will be giving them some sort of summative feedback, versus making them comfortable enough to admit that they don't know something or can't do something so they can grow. And I wish I could, this is the answer. You should find a way to balance. Sorry. Best I can do.
Oh, I love it. There was lots of discussion in the chat about ways to balance if you're in a pass-fail system in terms of, communication and summative narratives and formative narratives and the MSPE. Gary, did you pick up on any other potential questions in there? I think
No.
The other thing, we've been talking a lot about is the system right now. You can only be a dermatologist if you're honors in all 8 clerkships and, the highest performing student. And it's so fascinating, because do you really have to be that student in order to be a dermatologist? Or could you be an average student as measured by the clerkship grades, but have really great, visual acuity and recognize patterns of rashes and things like that? And I just would, I guess, maybe I'm too much of an optimist, but I would love to get to a space where you were matching in your specialty based on all of your attributes rather than, this attribute of honors in the clerkship or honors on the foundations courses and things like that.
And it gets into the matter of predictive validity again. And wouldn't it be nice to be able to design a system that is sensitive enough that dermatologists are selecting people for their programs based on what makes a difference in being a great dermatologist, and where OB/GYN people are doing, and some of those overlap, but not all. And it's really system-wide matters that involve people getting together, not simply on a one-on-one basis, but designing systems that really make sense.
There was also another comment about our sort of residency, the paucity of residency spots, and that certainly drives a more competitive culture, and sort of drives the assessment system. And then also, the number of applications that a program director has to review for 3 spots, and that really drives the assessment systems often. And again, as a purist, as an educator, I think it's a sad commentary on our system if it's not being driven by what's best for the students, but really what's best for the system. And it's around time and money. So there were some comments about kind of the system driving the assessment.
Objective indicators, which take very little time to rate and rank people, are the easiest to kind of get a large number of applicants down to a much smaller manageable number of applicants. And does that cut out people who have qualities that would make them great in whatever they're doing? The answer is yes, and it's unfortunate. And it is often a matter of resources that frustrate us all. I wish I had an answer.
All right, we've hit our time, so we're going to have to close this. Ed, thank you so much for doing this. Good luck with your move next week.
Thank you.
The next adventure in your life.
Yeah.
We appreciate it. So thanks everyone, and you'll be getting an email with the evaluation link in it shortly, if not already. So
great, lots of comments in the chat, Dr. Krupat. Just great discussion and great talk, and lots of opinions and thoughts on what to do.
Thank you.
And congratulations on you're officially retired and now moving. Is that to be a great grandfather? Is that what I heard?
I know, just a grandfather, although I'm a great grandfather.
A fantastic grandfather. That's what I meant.
But it's off to California.